Yes, I'm going to start recording. Good. All right. Good evening, everyone. I'm Dr. Turnham. My typical disclaimer, I am born and raised in the South. I'm from the South and will most likely live out my life in the South, but I do speak fast. Okay, so I will try not to speak too quickly for you, but typically the more slides I have to cover and the longer it gets, the faster I tend to talk. But really, everything is pretty self-explanatory. I'm just going over these slides as a courtesy to make sure everybody's got it. Okay. So, I'm Dr. Nancy Turnham. Dr. Betty Lang originally taught this section. Okay. This unit was Dr. Lang's last year. I did a different unit for the past several years, but now they've kind of swapped up a little bit. So y'all have to, I may stumble over my slides a little bit, hopefully not. But I want to make sure I give credit to Dr. Lang for her hard work that she did with this. I just went back in and added to it some and freshened some stuff up and played with the PowerPoint. So we should be recording. And we will go from there. Please, y'all, excuse me, please keep an eye on my pound cake.
How much longer do you think?
I don't know, but I left the cake checker in there for you.
Thank you.
Okay, life goes on. Okay, sorry guys. Okay, there's two types of hypertension. First, there's primary, also known as essential hypertension. Okay, this is the most common type of hypertension. About 95% of people with hypertension have primary hypertension or essential hypertension. This is about there's no known cause for the hypertension. Secondary hypertension, excuse me. I feel Murphy's Law coming on. I feel it. Okay, so secondary hypertension is due to a specific or identifiable pathology. Thank you. Historically, secondary hypertension in children most hypertension in children has been secondary to another problem, okay? However, we may see some changes coming up with these lower numbers being used to diagnose hypertension, obesity, and sedentary lifestyles. We may see more secondary hypertension due to, a specific identifiable pathology like obesity, sedentary lifestyles, so forth, as opposed to primary. But right now, primary is the most common type of hypertension. Now, it means that we cannot, primary hypertension, as I mentioned earlier, means we cannot identify a specific cause. Okay. It develops over a number of years. Secondary hypertension is usually an abrupt onset. You wake up one day and whoop, got high blood pressure. It's not gradual onset. Primary hypertension is often associated with one or more of the following: being overweight. You can also see some problems with lipid abnormalities, insulin resistance. Think metabolic syndrome. Okay, that often is part. It's obviously part of metabolic syndrome is hypertension, but you will see this insulin resistant lipid abnormalities and the obesity with primary hypertension. Causes of secondary hypertension: renal artery stenosis, pyelonephritis, glomerulonephritis, kidney tumors, polycystic kidney disease, which is usually the inherited polycystic kidney disease, injury to the kidney of some sort, radiation therapy affecting the kidney, again, part of that injury to the kidney. Let me go back to this renal artery stenosis, okay, and talk about that for just a second. Renal artery stenosis is, I don't want to say it's common, but I was always instructed that if you have a patient that's requiring more than 2 antihypertensives, we need to check their renal arteries to make sure there's not some type of narrowing. And this next month, March, I was talking to somebody today, will be 21 years I've been in practice, and I've probably had 10 people in 21 years that have had a renal artery stenosis, and we found it, and they had to go in and have stents placed and have it dilated and stuff. So, if you've got them on several medications and they're still hard to control, or if they come in with these really high pressures and they're hard to control, you certainly need to look at this and make sure that they don't have renal artery stenosis. Okay, so that is a very possible factor there. Causes of secondary hypertension continue to include hormone disorders, such as problems with the adrenal cortex, with a hyperaldosteronism, Cushing's syndrome, a pheochromocytoma would also do this as well. Okay. I skipped over that because it's pretty well self-explanatory, but I do want you to make sure that you know what hyperaldosteronism is in Cushing's syndromes with a high level of cortisol. It is a pituitary disorder. You may also have an ACTH secreting tumor elsewhere in the body. Okay, know these things. Okay, and the pheochromocytoma can also be a cause of the secondary hypertension. Okay, medications can certainly cause problems with hypertension. I have had a very thin, very active, almost, she was in her late 40s, present, I mean, she's skinny. She is like a size 2 skinny, okay? And she exercises, does CrossFit and everything, present with hypertension, okay? But she was in her late 40s and she was still on OCPs. And she developed hypertension. We took her off the OCPs, and her husband took the plunge, therefore, and took care of the birth control options there. But she came off her OCPs, blood pressure came back down to normal. Crazy. So late 40s, skinny, OCPs are doing it too. Corticosteroids can also cause elevation of blood pressure. EPO can suppress, which suppresses rejection of renal transplants, and also helps with bone marrow stimulation. That can cause hypertension. Obviously, cocaine or amphetamines can cause problems with hypertension, as well as tachycardia. Long-term alcohol abuse can cause it as well. And she says, Dr. Lang has a point in here about licorice, real licorice, not the strawberry kind, but real, like, black licorice. But you really got to eat a lot of it to have hypertension from it. Okay, but it is a possibility, the black licorice. A coarctation of the aorta, pregnancy-induced hypertension can occur as well. It's preeclampsia, AIP can occur, acute lead poisoning, hyperthyroidism, all can cause problems with hypertension, secondary hypertension. You want to be suspicious if you find secondary hypertension in children under the age of 15. Okay, secondary hypertension. Remember those little things we just talked about with secondary hypertension? Those are known causes of hypertension, but they're still secondary as opposed to primary. You want to be suspicious if you find secondary hypertension in children under the age of 15, people over the age of 65. Okay, remember that renal artery stenosis, especially in the age over 65, with other problems with peripheral vascular disease, peripheral arterial disease, heart disease. Think about that renal stenosis. Patients with persistent elevations of blood pressure after triple drug therapy that includes a diuretic, renal artery stenosis. Known and treated hypertensive patients with sudden marked increase in BP. There's got to be something going on somewhere that's caused a sudden change in her blood pressure. Hypertension with symptoms of headache, unusual patterns of sweating, palpitations, things that make you think of the pheochromocytoma. So you want to be suspicious of those things, okay? And think, why are we having this all of a sudden? What do we need to look at? What do we need to do next? Hypertension risk. So the risk of developing hypertension is obviously on the rise, okay? But part of it's due to we have aging baby boomers, okay? For some reason we have a nursing crisis, a nursing shortage, because we have a lot of baby boomers who are aging and retiring, who are aging and needing health care. It's also due to our sedentary lifestyle and our rates of obesity, even in young people and children, okay? And the obesity and the sedentary lifestyle often go hand in hand, okay? And you can see the different levels of the blood vessels there, your normal one versus ones with stress and activity versus the one that actually goes on and develops atherosclerosis there. Okay. Hypertension diagnosis. In other words, in order to diagnose hypertension, the blood pressure must be accurately measured. The patient should be seated, okay, for monitoring and for orthostatic changes, okay? And then when they're not seated, document as such. Okay. All right. So in other words, document your blood pressure seated, then standing. Document seated, document standing. Okay. When you take the two different readings. Okay. If you happen to have them lie down and then sit up and then stand, document which blood pressure goes with which position. Okay. The arm is to be supported at heart level. I don't like automated blood pressure cuffs unless I'm just pushed into a corner. I'm old fashioned. I really prefer to have a manual cuff. And I do check it myself. My nurse checks it, okay? But I go back and check it myself, sitting and standing, to make sure of what she's gotten if there's some kind of question. Okay. So support the arm at heart level. Let it rest on the side, let it rest on the armrest, whatever. Don't allow the patient to hold it in an elevated position. Okay. They want to hold it way up there. No, please put it back down. I got your blood pressure cuff on. Let's lay your arm back down. That kind of thing. Make sure the bladder cuff encircles at least 80% of the arm. Okay. Assess and record for both arms, because they could have subclavian still syndrome. Okay. So you want to make sure your blood pressure is pretty reasonably close within both arms. Okay. Measure at least twice on more than one visit in order to make that diagnosis of hypertension. Okay. So you're checking them sitting and standing. You're checking both arms sitting and standing. You're checking it at least twice on more than one visit. So you're measuring it on 2 visits or more, and you're checking it sitting and standing, each arm, 1 visit, because that's a little confusing right there. So you come in today, you get your blood pressure check sitting and standing left arm, sitting and standing right arm, documented. It's elevated in both arms, it's elevated sitting and standing. You come back next week or week after next, we do sitting and standing left arm, sitting, standing right arm, still elevated. So that's 2 times they've checked it on more than 1 visit. Okay. And it's still elevated, so we can make that diagnosis of hypertension. Does that make sense? Yep, good. Okay. Don't hesitate to check that blood pressure yourself, which is what I just mentioned earlier. I check it myself very often. Okay. Sometimes people don't inflate them right. Sometimes the patient's anxious when they first come in. Just make sure you watch it carefully and you watch it slow. You watch that needle, as it goes down. Make sure that it's all accurate. Okay. In case the heart rate's slow or if it's too fast. Okay. And make sure you pump it up far enough to capture the systolic number as well. Ambulatory readings correlate better than office readings with target organ damage. So when is ambulatory or home blood pressure monitoring advised? Anytime that you suspect the patient has white coat hypertension, okay? The patient says, my blood pressure is never this high at home. It's always low at home, blah, blah, blah. Keep me a written log. Logs are simple to make. You can make them yourself. You can download them off the internet. It doesn't matter, but you can print them out, give them to the patient, have them bring them back to you, okay? But they need to check their blood pressure. Often, typically, there are always atypicals. When you recheck a blood pressure yourself after your nurse checks it, and then you come in a little bit later and you talk with the patient for a little while, and then you get up to do the exam, you recheck their blood pressure comes back down. Typically, there's always some that it won't. I have one that does that, and her blood pressure stays up the whole time she's in the office. She'll bring me a list of readings from home, which I believe her. They're accurate. I've checked her monitor myself against my blood pressure cuff, and it's accurate. And her blood pressures are good at home. They're just high in the office. Okay. So you also have them check ambulatory or home blood pressure monitoring at home, away from the office, when they feel faint or they have symptoms of hypotension, dizziness when position change, dizziness throughout the day, feeling palpitations, so they have them check out their blood pressure at home. Okay. If they have episodic hypertension, I was talking with one of my little LPNs today. She is 4 months probably postpartum. She's early 20s, and she's having some fluctuation of blood pressures. I'm like, friend, your hormones are still kind of all out of whack, and you got a lot of situational stressors. There's a lot going on, but she's having episodic hypertension. So she's doing some home ambulatory blood pressure monitoring at home. She's doing some blood pressure monitoring at work, of course, because she's at the nursing home and she can do that. But those are one of the reasons that you want to check those blood pressures at home. Autonomic dysfunction is more common in diabetics. Okay. Drug resistance to hypertensives, you want to also check those blood pressures at home as well. I pretty much encourage all my patients with hypertension to check their blood pressures at home. I think the better you educate these patients, the better off they're going to be, the more compliant they will be. If you do your job of educating them and engage them in their care, if they buy in, they're more likely to have better outcomes rather than if they don't buy in. There are some people you can't sell nothing to. That no matter how much you educate them, you can't get them to join in and take care of themselves and do their blood pressures and so forth and so on. They just don't care, and they just won't do it. But I pretty much tell all my patients that they will to check their blood pressures at home, but definitely if they're having symptoms like this. Okay. Now, pre-hypertension. This is JNC7. and this is just go with it. Don't get hung up on it. Just know that pre-hypertension, the systolic blood pressure was 120 to 139, or diastolic of 80 to 89. Okay, these patients pre-hypertension require health-promoting lifestyle modifications to prevent heart disease. Okay, pre-hypertension was not addressed in JNC8, only in JNC7. Okay, so we have pre-hypertension goes. You see the words pre-hypertension? It's JNC7. Okay, because JNC8 doesn't have prehypertension. Neither do the new ones from the AHA. Okay. Prehypertension, JNC7. Okay. Word association. Okay. And the prehypertension stages are 120 to 139, or diastolic of 80 to 89. Stage 1 hypertension. Systolic is 140 to 159. Diastolic is 90 to 99. Okay. Stages of hypertension, stage 2. Okay. Systolic is greater or equal to 160, or diastolic greater or equal to 100. Stage classification is based on average of 2 or more seated readings on each of 2 visits, 2 or more office visits. So if you check the blood pressure on average 2 times on, let's see, if you check their blood pressure at least 1 time on 1 visit and 1 time on another visit, okay, and it's greater than 160 or greater than 100, then they have stage 2 hypertension according to JNC7. Okay. You have to have the documentation, and you have to document how you took it, what it was, and was there any different, the differences there. We're going to come back to JNC8. So let's just let JNC7 kind of ride. I do want you to realize what JNC7 is. JNC8 is what's here. JNC8 is what is new. JNC8 should be what we're all treating to. JNC8 should be what's on your certification exam. Okay. JNC7, in theory, should not be on your certification exam. I may have a question or two on JNC7, but if I do, it will be very clear cut and very simple. But in order to give you a well-rounded education, I've got to let you see where we were to what we're going to. Okay. We just talked about JNC7. We're going to talk about JNC8, and then we're going to talk about the AHA guidelines in just a few minutes, okay? So what's the bad about high blood pressure? It doesn't hurt. I can't feel it. I can't taste it. I can't see it. I can't, hear it. So what's so bad about it? Well, a lot of things. It can cause problems with enlargement of your heart. You can get that LVH going on. You can have some angina. That's a precursor to what? That big old MI that you may have. You can certainly have some heart failure, especially associated with that stretched out heart you've got going on. It may lead to problems with a stroke or even TIA, just TIA symptoms. It can lead to kidney damage, okay, for chronic hypertension that's uncontrolled. Obviously lead to peripheral arterial disease because these vessels are getting tired of all this pressure that's on them. You can cause problems with retinopathy, and you can lose your eyesight. There has been increased documentation of dementia and cognitive impairment in patients with uncontrolled hypertension because it's just the blood's not getting to the brain like it needs to because it's going elsewhere because it's being forced, it's being forced through at such a rapid rate, and then you've got all these arteries and vessels and veins that are just having to respond to it, and it's a huge mess. So uncontrolled hypertension can lead to dementia, and it can lead to retinopathy, peripheral arterial disease, kidney disease, stroke, MI, LVH, heart failure, etc. Target organ damage as a result of uncontrolled hypertension. Obviously, the first thing we think about is the heart. Okay, it's the most common organ to be targeted with hypertension. If you control this blood pressure through antihypertensive therapy, management of lipids, and even some aspirin therapy, it can decrease the risk for heart disease. Okay, you want to hold that aspirin until you get the blood pressure controlled. Let's don't give aspirin to that patient with a systolic of 200, a diastolic of 110. Because when they go have that little stroke from that little aneurysm that's brewing in their head, they're going to bleed pretty good with that aspirin. right? So we don't want to give the aspirin until we get their blood pressure controlled. Then we add the aspirin therapy. Okay. So the best way to prevent heart disease, ischemic heart disease related to hypertension, is to control the hypertension, control the lipids, and then add the aspirin for prophylaxis. Okay, so let's look at this. First, what's causing this patient's blood pressure to be high? Okay, they're sitting in front of you and you think, okay, so I've got to figure out why their blood pressure is high. Is this primary hypertension or is this secondary hypertension? I need to look at this and see. So we're going to ask the right questions, okay? Who, what, when, where, why, and how. Okay, that's what we're going to ask. Detect hereditary and environmental risk factors. How old is this patient? Are they young, less than 15, less than 20, less than 30? Are they old, greater than 70, greater than 80? What is their diet like? Do they have a lot of salt intake? Do they eat a lot of pork, ham, whatever? Do they resalt everything without tasting it? Do they have a lot of carbohydrates? Are they overweight? Do they eat a lot of high-fat diet? Do they drink a lot of caffeine? Ask specifically about coffee, tea, and Mountain Dew, Diet Coke, whatever. And of course, all these little energy drinks that are out there. Y'all wouldn't know about energy drinks. The students know, would you, to help you stay up and study? Y'all are good students and don't do that, do you? I've seen them at Walmart. It says she's got down there to say some at Quick Marts. I've seen them at Walmart. Yep. Ask about their exercise. Do they get exercise or not? What is their stress level? Because stress can certainly cause problems with some, arterial spasms and cause some little angina going on there. Do they have sleep apnea? Sleep apnea absolutely is a risk factor for hypertension. Okay. What is their personal medical history? Okay. Do they have any personal history medically of hypertension or preeclampsia or whatever? Do they have a family history of hypertension, heart disease, stroke, etc.? Do they use prescribed drugs that are stimulants of some sort? Okay. Or do they take illegal street drugs like, I don't know, a little meth or cocaine, whatever? Do they use a lot of tobacco or alcohol that would be causing some, narrowing of the arteries and causing some spasms? What's going on? So ask all the right questions. Don't be afraid to ask questions, okay? Ooh, what happened here? Did I have a completely blank slide? I still see that. What happened? Huh. Well, I don't know what to think about this slide because it's on the printout. Well, I don't have the printout, Marjorie. I'm in bad shape. Hang on just a minute. You'll have to bear with me. I have to load my PowerPoint because I just loaded it up. Ah, that's hilarious. Okay. I'm cracking myself up. Y'all bear with me. I will get it all done. Enable editing. What slide number is this? Slide number 18. We are moving slow. My cake is burning in the oven. For those of you who got here late, I'm very sorry. I have a cake in the oven and it's probably burned up because it spilled out and it's burning right merrily away. Okay. Oh, thank you, Stephanie. That is so sweet. Okay. All right, perfect. So let's see, what's causing this patient's hypertension? I'm going to use Stephanie's notes. Thank you, Stephanie. First, you want to make sure you perform the physical exam in the right way. Okay. Physical exam is objective data. The questions you were asking was subjective questions words that were given to you by the patient describing things. Objective is what you see with your own two eyes, you hear with your own ears, you smell with your own nose, so forth and so on. Okay. So physical, objective data. Okay. Subjective data, patient tells you. Okay. So we're going to perform the correct physical exam to detect modifiable risk factors. What can be fixed about this patient, okay, to make their blood pressure better? Possible indicators of secondary hypertension. So what are indicators? The obesity, the hyperlipidemia, the sedentary lifestyle, the peripheral arterial disease, the angina. Could they already have renal artery stenosis? Do they already have kidney disease? There's a possible target organ damage. You're going to assess for those things on the physical exam, okay? What you can see, hear, smell, all with yourself, not what just the patient tells you. Accurate blood pressure measurement, both arms supported at heart level. We've already talked about that. Sitting and standing, check it yourself. Do their BMI, check their waist circumference, palpate their thyroid gland, okay? See if it's enlarged. Do you feel any nodules? Okay. Do that full neurological exam, make sure they're not having any deficits there. Do that retinal exam to make sure about that. Look for AV crossing, the nicking. Okay, look for all that on this exam. Okay, Thank you very, very much for that, Stephanie. Now, PMI, that point of maximum impact there, right? Can you feel that PMI? You can feel it with an LVH. That may result from hypertension. Listen to that heart. Listen for the murmurs. Listen for the sounds of aortic stenosis, that mitral valve prolapse, so forth and so on. Listen for that fourth heart sound as well. Auscultate the lungs. Do they have any crackles, any rails? What's going on with this? Do they have any objective signs of congestive heart failure? Okay, listen for bruits in the carotid areas. Okay, both carotids. Listen for it in the abdominal wall to make sure they don't have abdominal aortic aneurysm. And then also, after you auscultate that abdominal wall, you also want to go back and palpate for the abdominal aortic aneurysm. Okay, the femoral arteries. Listen for bruits there as well. It'll be indicative of that renal artery stenosis. Okay, are the kidneys enlarged? You may not be able to feel that on most patients unless they're pretty thin. The aortic pulsation, you may be able to see it if they're thin, okay, as well as feel it. Even with a somewhat obese patient, you may be able to feel if it's an aneurysm big enough, you can feel the aortic pulse, okay. Check the lower extremities for edema. Make sure they have positive pulses. Look for those signs of discoloration consistent with peripheral arterial disease or peripheral vascular disease, okay, and venous stasis disease as well. Get the blood work done, okay? So you want to get and the other diagnostic tools, including an EKG. Check that urine, see if they're spilling protein over in their urine. Check their sugar levels to see if they have some prediabetes or diabetes going on. Check their hematocrit to see if they are anemic, which would cause some problems with hypertension as well, because they're don't have enough hemoglobin, and the hemoglobin's low, so therefore they're having loss of volumes, therefore they're having to pump harder, which makes their heart work harder, which makes their blood pressure higher. So you want to look for that as well. Check their potassium to make sure there's no fluid electrolyte balances there. Creatinine, GFR go together. Calcium obviously goes there. Fasting, lipid profile, and triglycerides as well. Okay, so those are all things that are important to look at. So definitely look at the EKG. Definitely look at that UA. And these other things, you can get a CBC. I like to know what the platelet's doing. I like to know what the hemoglobin's doing, as well as their hematocrit. I like to know what the white count is. I'm just nosy. Obviously, blood glucose, potassium, creatinine, GFR, calcium are all part of that CMP or Chem24 panel. Fasting lipid profile should always include triglycerides if it's a complete lipid profile. And you should look at that to see if you can have anything that needs to be fixed there. And because that will also contribute to the heart disease and organ target organ damage. Can't speak. Okay. The goal of primary hypertension management, okay, to get the systolic pressure down, okay. After 50, your diastolic pressure peaks and begins to decline. So your goal after 50 is to fix that primary systolic blood pressure, okay. And elevated systolic pressure with a widening pulse pressure are better indicators of stroke than diastolic pressure in those above age 50. Okay? So if you look at their pulse pressure and their systolic pressure is a better indicator if they are elevated for stroke as opposed to those under the age of 50 years. Okay? Antihypertensive have a greater effect on systolic than diastolic. Okay? This helps narrow the pulse pressure. Does that make sense? Yeah? Okay. Yeah, don't want to lose y'all. Just making sure. JNC8 is in red. JNC8, you need to know back and forth like front and back of your hand, okay? JNC8 should be on your certification exam, so therefore it will be on your Unit 2 exam, okay? You might have maybe two questions on JNC7. I cannot imagine myself writing more than one question on JNC7. If I write JNC7. But you got to know where you've been to know where you're going. JNC8 is going to be on your exam. JNC8 should be on your certification exam. The question is I don't know if AHA numbers will be on your certification exam or not, because it came out right at the cutoff mark for the certification exam questions. Okay, when we write questions for certification exams, there's a cutoff date of October, November. Okay, and then so October, November of last year, which is right when this came out, not JNCA, the AHA guidelines, those came out right at that October, November mark, okay, of 2017. All the test questions for 2018 have already been written at that point. So therefore, if you test in 2018 for certification, that should not be on there. But if you test January 1, 2019, then the AHA questions could be on there. Does that make sense? Okay, thank you. All right, so we're gonna push on regardless. Yes, Charlene, you will, but some of you may choose to test in December of 2018. Just depends. But we'll talk about that ad nauseum, and I do mean ad nauseum, come fall semester. We're going to be BFFs by the time fall semester gets here. Okay? Time we make it to December, we're all going to be just real close, and we're going to be holding hands and singing Kumbaya, and yeah, but we'll talk about it come fall semester. But I just want to make sure why I'm telling you all these. So you need to know where you've been, JNC 7, where we are now, JNC 8, and where we're probably going, which are the AHA guidelines. So let's look at JNC 8. The goal of hypertension management, according to JNC 8, is for a blood pressure to be less than 150/90 in patients age 60 or older. Okay? If you are under the age of 60, your blood pressure should be less than 140/90. And that is a whole lot more forgiving than these AHA guidelines. Okay? A whole lot more forgiving. 150/90 or less for 60 and older, 140/90 or less for up to age 59. Okay? How are we going to get them to those numbers? Well, we're going to figure out which one we're going to do first. And it's not really so much it's not the chicken or the egg. You got to do all these things together at the same time in order to make this happen, okay? So you start with lifestyle modifications first, okay? You work on weight reduction, okay? You try the DASH diet, okay? You work on reducing sodium. You that 1,600 milligram sodium diet DASH plan has a 1,600 milligram sodium DASH diet has effects similar to single drug therapy. So you can put them on diuretic, or you can put them and make them take a pill every day, or you can have them follow 1,600 milligram sodium DASH diet, okay? And they'll get the same effects because they're very similar according to studies. However, patients are not compliant with a 1,600 milligram sodium DASH diet. They want to be, they have good intentions, but they just can't make that happen. And so therefore they're more likely to do a pill, because, and even then they're not always compliant, but we do the best we can. But we got to try to encourage lifestyle modifications, dietary modifications first if we can. Lose weight, exercise, do what we're supposed to do. Cut back on the alcohol intake. No more than 2 drinks a day for men, no more than 1 a day for women. Get them to quit smoking. You'd think after all these years we could get them to quit smoking. But no, people still want to go to the Marlboro Ranch. Which I hear it's really nice. I'll give them credit. I do hear it's really nice at the Marlboro Ranch, but I just don't think I could smoke cigarettes to go to the Marlboro Ranch. I just don't think I could do that. But that's just me. Okay, so get them to make these lifestyle modifications. Assess the lifestyle before you give advice. Don't just presume. Okay, don't just make decisions based on what you think they're doing. You need to ask them and get their input. Sell them on the product. Sell them on it. Get them to buy into this. This is, you got to get them to buy in and understand and want to participate and want to be better. Okay. Set goals with patients. Don't set them for them. Set them with them. Okay. That buy-in. Use it motivational interviewing techniques. This is like what I'm talking about. They've got to be engaged. Okay. Otherwise, it's because I'm the parent and that's what I said. And that doesn't work for, almost works for no one. Okay. So, and I have another blank. Stephanie, I have another blank screen. What do I do when lifestyle changes do not lower hypertension to goal? Well, then you move on to something different. And Stephanie's going to help me out. She's going to copy and paste for me. That's what she's going to do. And I'm going to look and see what I can come up with. I apologize, guys. I should have saved this to PDF, and it wouldn't have been like this. Okay, I see what it is. It's because it's got a blue background in it. Okay, I can do it. All right, choose antihypertensive drugs that are aimed at one or more of the interactive systems that defend and strive to balance arterial pressure. Woo! That's a bunch of words, Dr. Lang. Okay, so choose antihypertensive drugs that will work to balance arterial pressure. Okay, the first one is to address that extracellular fluid volume or diuretics. Okay, your second choice is to look at the renin-angiotensin system. So first you want to try diuretics. If that doesn't work, then you want to go to ACE inhibitors or ARBs. Okay. All right. Then your third line choice is the calcium channel blockers. Okay, because the heart needs calcium to contract. The calcium channel blockers decrease the heart's contraction by blocking the movement of calcium into the heart. They also relax the muscle cells and arterial walls and therefore lower blood pressure. So first try diuretics, then you try the renin-angiotensin system with either ACE or ARBs, then you try the CCBs. If you have to go to the fourth thing, then you're going to look at the sympathetic nervous system, which include beta blockers, okay, to slow that heart rate and reduce the heart contraction. You can try clonidine. You can try alpha blockers. Alpha blockers aren't always great, but they will help sometimes in patients who are pretty resistant. Okay, so you've got all four stages right there. When you start with the first one and work your way down. Okay, let's see what's next on this thing. Okay, now JNC8 recommends an ACE, ARB, CCB, thiazide diuretic for non-Black population. Okay, so you get to choose which one you think you want to use. Okay. A CCB or a thiazide diuretic for the Black population usually works best genetically. Okay. An ACE or an ARB in patients with chronic kidney disease is indicated, okay, if they're already on a CCB or a diuretic and there's some renal insufficiency going on, you want to add on that ACE or ARB to improve kidney function. Okay. Does that make sense? This is going to make over what pharmacology taught you. But JNC8 recommends starting with the diuretic, the ACE, the ARB, or the CCB. So you can choose any one of those categories. So instead of going to the first, what we just looked at just a minute ago on that last slide. So instead of going just to the diuretics first or just the renal angiotensin system, you can choose 1, 2, or 3 as your first line starting point, according to JNC8. Okay? If they're not African American. Okay, if they're African American, you need to start with that thiazide diuretic or the calcium channel blocker because genetically this is going to work better for them. Okay, I'm fixing to go on the rabbit trail just for a second about these things about genetics. We are increasingly moving towards genetics-based medicine. Okay, I don't know if y'all get that idea or not. I do, because we're becoming more detailed. Look at that. Was it 23andMe? Has anybody done 23andMe yet? The DNA test? No? Okay. No yeses. Has anybody done Ancestry.com, Ancestry DNA? Totally did. You have. Okay, Margie, did you do 23andMe or Ancestry? And Kelly, which one did y'all do? Can I tell you? Ancestry. Okay. Kelly, what about you, Margie? Ancestry. Okay. Margie did Ancestry. The 23andMe is supposed to give us something about medical diagnoses and stuff. I don't know fully about that because when I looked at the prices, and I'll tell you, my husband's horrible to buy for, so I bought him an Ancestry DNA kit for Christmas, which neither one of us have done yet, but we may do it tonight before we go to bed. I may set it off tomorrow morning. I think I need to do that. Anyway, but again, we're becoming more and more genetically looking at genetics and how can we work with genetics to better tailor these things. I have sent out patients saliva for testing to see what drugs they respond best to. Okay. I think it's fascinating. There's a simple buccal mucosa swab from Boston Heart Labs and other tests as well, I'm sure do this, that will tell you if these patients are Plavix responders or not. You know, if they're not Plavix responders, you don't need to put them on there. They'll tell you about their risk for myopathy with statin drugs. It's just from a simple buccal, just from swabbing the inside of their mouth for 2 minutes, you can tell that. It's really cool. Yes, it is. It is fairly expensive. It's probably like $1,000, but typically insurance covers it once in your lifetime. I'm kind of sad I'm not teaching the lipid course this time because I love talking about ApoE genotypes, and I get really excited about that. And that's another thing you can tell from that simple swab. You can also look at their ApoE lipoprotein genotypes and stuff. But we're becoming a more progressively more leaning towards genetics to help us treat these patients and tailor medicine towards these patients, which is really cool. So I'm going back on the mainstream. I'm off the rabbit trail. We're back to, oh, yes. There you go, Lydia. There you go. Site clinic you work in does not prescribe an antidepressant or most drugs without genetic testing first. Yes, that's exactly right, because there's a lot of drugs. That's not the one that I use. I can't think of the one I used right now. That was the whole saliva testing for the medication sensitivities. It wasn't Genocyte, I don't think. It was somebody else. But they gave me a whole list, a whole stack. It wasn't just psych medicines, it was a whole bunch of medicines. But sure enough, some of these things that these patients have been on, they were not doing well with. And we changed their medicines, and they did great with it. It's fast. It is just a whole fascinating thing out there. But anyway, oh, that's cool, Lauren. See, now why did your husband get it done instead of you? Didn't you know you were supposed to get that done too, Lauren? Statins, yeah. So that was a buccal mucosa swab. That is awesome with the statins. The buccal mucosa swab from Boston Heart Lab will tell you about statin myopathy risk. It'll tell you about Plavix. It'll tell you about clotting factors, including factor V, whether you're higher risk to clot than the normal population on hormone based or factor V Leiden. It will tell you, I think I said Plavix already. It will tell you about your ApoE genotype. Yeah, I'll tell you all these things, which is really cool. Okay, I'm off the rabbit trail, back on here. Where do I start with drug therapy? JNC8 recommends ACE, ARB, CCB, or thiazide diuretic for non-African population. African American populations do best with calcium channel blockers or a thiazide diuretic first line. Okay, an ACE or an ARB in patients with chronic kidney disease, you add on the ACE or ARB if they're already on something else to improve kidney function. If their kidney function is elevated, in other words, if they have poor GFR, stage 4, stage 5 kidney disease, especially stage 5 for sure, you have to get rid of the ACE and ARB because it's making it worse. Okay, no longer becomes helpful. Can other antihypertensives have been used as first-line therapy? If contraindications or other comorbid illnesses are present, you could use a beta-androgen blocker or a diuretic beta blocker combo, okay, if you need to, first line, okay? But you need to document in the HPI compelling reasons to use a drug other than those recommended as first-line agents. So let's go back and look, okay? If you have a African-American patient and you're not putting them on a thiazide diuretic, but you're putting them on a non-thiazide, so say we're going to put this patient on Lasix first line rather than putting them on Maxide, okay? And why we're going to do that? Because they have severe dyspnea, they have decreased LVH, they have decreased ejection fraction, and they have fluid, in their lungs. They're in acute CHF, so you're going to put them first line. They present with this for the very first time, never been on a blood pressure medicine, and you're going to put them on Lasix first line because they're in acute CHF. You're going to document that in your HPI. Okay. So if contraindications or other illnesses are present and the necessity is to start them on something else, then you're going to document that in the HPI. Is why you're doing this as first line agents to cover yourself, okay? Because we are now there. It can worsen. Okay, Maria asked if we have a patient with gout and we want to use thiazide diuretics. It is not a flat out contraindication, but you do need to be aware of it and how severe is your gout, what were your numbers. And when was the last time you had a flare? And you need to monitor for it because it can trigger a flare with their gout. If you add thiazide diuretics to them. Good question. Okay. Take compliance issues into consideration. Nothing works if it sits in the bottle. Okay. Melody asked, can you use the chlorothiazide done with gout? Yes, you can. Instead of HCTZ, you can do that. But you got to watch, make sure it's going to work. It's not quite as effective, in my opinion, personally. Okay. Nothing works if it sits in the bottle. Okay. So if they're not going to take it, it's not going to work. You got to make sure that you work on this compliance with medications by tailoring the therapy. Think about first side effects. Okay. Number one thing. If something is not going to be effective for this patient because they're concerned about side effects, you've got to address those fears now. Okay. You got to think about how can I make this more compliant. If you're going to give them something that has to be dosed 3 times a day, I mean, amoxicillin is a great drug, okay, but it's 3 times a day, and it's really hard to get somebody to take something 3 times a day for 10 days. It's a lot easier if we can take something once a day. So same thing with blood pressure medicines. If we're having to take something 2 and 3 times a day, it's not as easy to take as something that's taken once a day. Cost is a big issue, okay? Because if it's going to cost you money, it costs a lot of money to pay for something. Some of these newer drugs, they're not going to be as likely to get that because they've got other things they've got to buy. They have food. Do they have to buy? They have bills they have to pay. They're compliant. They probably have other medications they have to buy. So cost is a big issue. Here in the South, we now, in Alabama, have Publix and have now for probably about 7 or 8 years in Dothan. And love Publix. And they have just rolled out a brand new program. Now, first of all, Publix has a great program where they have lisinopril free, they have Norvasc free, they have Singulair free, they have Bactrim, Amoxil, Keflex, Cipro, Metformin, all free with a prescription. Okay. They have 9 days with a prescription. Okay. Now they have Losartan, which is Cozart. They have a whole bunch of others. There's Losartan. All I can think of right now on blood pressure is Losartan, but there's others because Norvasc was already free. The Losartan is now $7.50 for a 90-day supply with a prescription. They have Aricept for $7.50 for a 90-day supply. They have Flomax for $7.50 for a 90-day supply. They have Seroquel. Lydia, they have Seroquel for $7.50 for a 90-day supply. They have Trazodone, they have Elavil, they have Zoloft, they have Zocor or Simvastatin, they have I said Flomax already, didn't I? A whole list, a whole page full for $7.50 for a 90-day supply. This helps tremendously with compliance, as you can imagine. Okay, so not only if I can't get it for free, if it's not, and they also have Maxide HCTZ with that $7.50. They have both of them separately, and they have Maxide and then they have HCTZ for $7.50 for a 90-day supply at Publix now. That's something new they just rolled out in the last 3 or 4 weeks, which is really, really neat, and that helps with patient compliance. It helps them to adhere to therapy, and you can always document that in your note. And yes, it's probably a little bit of overkill, but at least you can document, hey, I told you for something was free and you still didn't go get it. Are you kidding me? What are you doing? But failure to adhere to therapy is the number one reason for refractory hypertension because they ain't taking it in the first place. Okay. I get this list. I got it from the pharmacy. You can download it from Publix.com. Okay. I'm sure that Winn-Dixie probably has something similar. I'm sure Kroger has something similar. What's another big Safeway? Do they have pharmacies at Safeway? I don't know. I don't have any Safeways around here. We have Winn-Dixie's and we have Publix and we have Walmart, of course. And Walmart, of course, has a $4 list, which translates into $10 for a 90-day supply. But $7.50 is cheaper than $10. And they have a drive-through. And you don't have to go to Walmart to get them. There's just a lot of reasons here. But these Part D patients, especially, need these $7.50 medicines for 90 days because that keeps them out. They can just do that cash pay without affecting their Part D. And this keeps them out of the donut hole longer, which is huge. huge, especially with Aricept. Oh my gosh, Aricept. Okay. I don't know, Lisa, you may want to look at the Publix one and see how it compares to the rest of these because I haven't seen Aricept on anybody else's. That one sticks out in my head. Or Seroquel. Or Zocor for that matter. Simvastatin. I've seen Pravastatin on there, but I haven't seen, and I've seen Lovastatin, but I haven't seen Simvastatin except on Publix. But I haven't looked since Publix came out with theirs. So you can look at that and see. But compliance is huge. Okay. Now, two approaches to fixing hypertension here. So if the blood pressure is still not controlled, then we're going to increase the dose of the first drug before adding a second one. We're going to try to max it out if we can. The second choice is to continue the initial dose of the first drug and add a low dose of the second drug, depending on what your patient needs. Approach number one ensures that the first drug failure is not dose related. Okay. So that, in other words, if you max out the dose and it's not just that you didn't give it enough time or give it enough medicine to make it better, whereas the second approach reduces the chance of dose-related side effects. The first thing that comes to my mind when I look at this, increase the dose of the first drug before adding a second one, the first thing that comes to my mind is Norvasc or amlodipine and that pedal edema. Okay, they get this pedal edema, and it's terrible when they start hitting above 10 milligram doses. Even with 10 milligrams, some of these little old ladies will get that pedal edema going on. So sometimes I'll do 5 milligram Norvasc and 10 milligram lisinopril, and I go ahead and combine them rather than maxing out the Norvasc because of that reason. Okay, so those are your two choices. When the blood pressure is more than 20 millimeters of hygronium systolic or 10 millimeters diastolic above goal, consider initiating therapy with low doses of 2 drugs. Okay. So if they've got and that's kind of tricky, that it says consider, it doesn't say you have to. Okay. But if their blood pressure is elevated enough, more than 20 points systolic or more than 10 points diastolic, you can consider starting with 2 low dose drugs like lisinopril HCTZ. Okay. You could do that to try to get them to go quicker. Okay. You can consider that. It's not a mandate. You can consider that. Okay. When you're getting ready to change things and you're having you have side effects, okay, you want to discontinue a drug and start a drug from a different class, okay, if they've had some type of reaction. Note that if a patient has been on a beta blocker, the dose should be tapered down before you stop it if you can to avoid rebound hypertension, okay? Now, just 1 second, guys. Okay. So we're doing this, discontinuing the drug and starting a drug from a different class if that patient is having problematic side effects that bother them, or if they don't seem to respond to initial therapy. Okay. Beta blocker, taper before discontinuing. Otherwise, you can have rebound hypertension from that. How many drugs does it take to reach goal? Okay. I hope somebody's old enough to appreciate my Tootsie Roll Pop. I looked really hard to find a clean version of that because there were some not so clean versions. I was very disappointed of my cartoon because it cracks me up. Okay, I have 2 best friends. They're both nurse practitioners, and one of them is a cardiology nurse practitioner, and she thought that was hilarious. And she said it only took me a 1. She said I never got to a 2 or a 3. She always crunched in that Tootsie Roll Pop every time to get to the center of Tootsie Roll Pop. Okay, so how many drugs does it take to reach goal? Many patients who are hypertensive will require 2 or more medications to achieve their blood pressure goals. Eek. Real life. Eek, 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 eek. I have a lot of patients who are just on blood pressure medicine in my practice, but the literature says that it's like this. But in my practice, I really have a lot of them that are just on one. Probably about half and half. I have half and half. Half are on one, half are on more than one. Okay. But the literature says that many patients require 2 or more blood pressure medicines to achieve goal. Okay. Diabetics underline may, need 3 drugs to control hypertension. May. Okay. But you got to get them to buy in on the problem and how to fix it. Okay. You got to get the cooperation. So a 1, a 2, and a 3. It's may take to get to the center of a Tootsie Pop. And it may take as many 3 or more antihypertensives to treat your diabetic patients. Isolated systolic hypertension, ISH. Blood systolic's really high, diastolic's really low. Most common in the elderly, okay? You usually give them diuretics and calcium channel blockers, okay? Thiazide diuretics are often effective in the elderly, okay? But age-related heart failure and GFR may make those thiazide diuretics ineffective, okay? So, calcium channel blockers are good treatment for this isolated systolic hypertension in the elderly. Okay, I would probably stay away from the thiazide diuretics because you've got to look at that GFR and see what's going on. Okay, I keep losing half. This is what happens when I don't treat hypertension the patient with unstable angina or acute. I didn't save this down to PDF before I uploaded it. I uploaded it as PowerPoint, so that's why half my slides are missing, and I apologize. I have to keep looking at the titles are. Okay. So for this patient with unstable angina or that's having acute MI, you want to treat them initially with a beta blocker and an ACE inhibitor. Okay. You want to use both because you want to protect those kidneys and you want to control their heart rate. You want to improve that pump. And so you're going to get the blood pressure down with the ACE. You're going to help the kidneys with the ACE. You're going to control that pump, control that heart rate, and improve the pump with the beta blocker. Okay. And that was for those patients with unstable angina or acute MI. Okay. Our next one is patients with stable angina. Okay. Stable angina. Their first drug of choice is a beta blocker. Help that smooth muscle contraction there, help that pump. A long-acting calcium blocker can be used as well for those patients with stable angina. Okay. How do you know when it's heart failure? Okay. Dry cough and shortness of breath. They may have some frothy pink sputum. They may not, but usually a dry cough, shortness of breath exertion, that lower extremity edema. The blood pressure may be normal. They may have a little bit higher heart rate. You have that JVD, that jugular venous distension when they lie flat or at a 30 to 45 degree angle. You can have that distension. And when you palpate that liver, you have that hepatojugular reflux noted up there. Bibasilar rales can be present. Maybe present as diffuse bubbling rales with pulmonary edema. May have some wheezing present. On the chest X-ray, you see signs of pleural effusion. You may hear it's flat or dull. Percussion. Breath sounds may be decreased or absent altogether. You may see when they inhale, you may not hear them inhale. You may hear maybe an inspiratory lag. In other words, you don't hear it as quickly as they do it because it's got to make it, the lungs are having trouble expanding. Okay. The liver may be enlarged, tender palpation, ascites may be present, sacral edema may be present, peripheral edema usually present. Peripheral, you see that lower extremity swelling. Okay. Sometimes you can see it in their hands. Some patients can have skinny little ankles, okay, and their whole belly is just huge. All the CHF is in their belly. It's not very often I see that, but I have seen that some in the nursing home. Okay. With that. Nice picture of congestive heart failure. Okay. The heart obviously is quite big. You cannot put your fingers across that, okay? All right. You can't really see the hyla here, okay? You see the increased pulmonary veins here, okay? And of course the edema here and here, okay? That heart is huge. That's a big heart right there on that. When to use a loop diuretic? With heart failure, you usually see this peripheral edema. Obviously, get the good HPI, get the chest X-ray, lab work, etc. But you definitely want to use that loop diuretic, start with that Lasix or Bmex, depending on what the history dictates. Okay. Heart failures usually result of systolic hypertension and ischemic heart disease. Those with decreased renal function, so a creatinine of 2.5 to 3 or a GFR less than 30, which is going to be stage 4 chronic kidney disease. You have to be careful with the loop diuretic with those. Okay. A potassium supplement is typically needed. Okay. You could use spironolactone for its potassium sparing effect. However, from a practice standpoint, and mind you, This will be 21 years come March that I've been in practice. I've done internal medicine all my career. Okay. In the last, this is 2018, the last 6 years, 7 years, 8 years, I've done nursing home / internal medicine. And spirulactone is great, but it doesn't really help a lot to me unless I've already gone on one type of diuretic and I'm having to add on that aldactone for a second diuretic. Okay. I will do that. If we have ascites secondary to cirrhosis, I will add on that aldactone to pull off some of that ascites. Okay. Otherwise, we go with Lasix or Bmex pretty much for this. Okay. When do I use Lasix? When do I use Bmex? If they're naive, they're not on a diuretic. You lost me? Uh-oh. Anybody else lost? Okay, good. Okay, good. TNSU. I'm gonna let you come back. Okay. So Lasix versus Bmex. If they're diuretic naive, I usually go with the Lasix first line. Okay. If they have been on the Lasix and they're not responding to it, sometimes I'll add Zeroxolin to it for a few days. Sometimes I'll just, if they're just have Lasix fatigue, for lack of a better word, I will go ahead and just I'll take them off the Lasix, put them on the Bmex. Okay. But I don't usually start with Bmex. I usually start with Lasix first line. Okay. That's just me. All right. Hypertension in children and adolescents defined as a blood pressure that is 95 percentile or greater. Oh, this starts that AH. No, this is still children and adolescents. So it's still GNC8. 95th percentile or greater for age, height, and gender. Okay. A blood pressure reading that is at the 95th percentile or higher for that child's age, height, and gender. Okay. Look at the reasons for secondary hypertension: obesity, sedentary lifestyle, poor dietary habits, etc. Okay. Are they having symptoms of pheochromocytoma? Let's look at that as well. Young children under age 15 especially may need referrals to a cardiologist or a nephrologist for additional help. If it is primary hypertension, lifestyle modifications will help. And it's easier to train them when they're young than when they're old and set in their ways. Medications should be used when necessary. Okay. Hypertension in women. Ask about those ACPs. Remember my friend Skinny wears size 2. Try to wear size 0. I don't know. Does CrossFit. She had hypertension related to ACPs. Okay. Women don't always think of that as a medication. It's just the pill. So keep thinking about that. Avoid ACE inhibitors and ARBs in women whom pregnancy may occur because they can cause decreased blood flow to the placenta, and they may cause some birth defects. Okay. No ACE and ARBs. Okay. In women who are pregnant. Hypertension during pregnancy. Apresoline is good. Aldomet is good. Okay. Because of the way everything is distributed during pregnancy, we can have postural hypotension. Okay. Everything rushes down. Gravity flows down. Okay. Pulls it down. So make sure that you advise them to change positions very slowly to avoid syncope. Okay. Because we don't want to fall and be pregnant and then have an injury and be really bad. Okay. Preeclampsia is hypertension that occurs or becomes worse after the 20th week of pregnancy. It is characterized by albuminuria, hyperuricemia, and you may or may not have coagulation problems. You may have some blood clots there. Okay. It may require IV antihypertensives and anticonvulsant therapy to keep you from going into seizures. Okay. Preeclampsia is a hypertension that occurs or becomes worse after the 20th week of pregnancy, and it's characterized by the albuminuria and hyperuricemia. Okay, those are two things that characterize that preeclampsia. Okay, and let me jump over here. Okay, hypertensive urgencies. A hypertensive urgency is a blood pressure that's more than 180 or 100 or 110. Okay. You can treat it in the clinic, although there are no really big guidelines to say give clonidine every 30 minutes, blah, blah, blah. You have to use your best judgment. Okay, you can try simple intervention by having the patient lie in the dark room for 30 minutes. This can drop them as much as 20 points on their blood pressure. Okay, we just mentioned that clonidine. You can use that for a quick response in the clinic, get the blood pressure down, and then start them on something else. If you drop the blood pressure too much too quick, you can cut off blood flow to the heart, and it can cause ischemia. You can decrease blood flow enough that it will cause spasms, which will cause ischemia. That's a more accurate statement. But you have to pay attention to this and see. So blood pressure greater than 180 over 110 is considered hypertensive emergency or urgency. Okay. All right. I'm sorry, that was a hypertensive urgency. The next one is hypertensive emergencies. An emergency are those with severely elevated blood pressure and who do have acute target organ damage. Okay. So an urgency is without the organ damage. An emergency. Oh my gosh, all I can do now. I'm sorry, y'all. It's getting late. All I can do is hear that song in my head now. It's an emergency. Was that Foreigner? Yeah, okay. All right, so those with severely elevated blood pressure and acute target organ damage, such as encephalopathy, an acute MI, and simple angina, pulmonary edema, eclampsia, stroke, head trauma, arterial bleeding, and aortic dissection, those are part of that target organ damage, okay? Patients with an elevated blood pressure and target organ damage are considered an emergency, okay? Acute renal failure could also fall under there. Yes, good, Rebecca. That's a good point. All right. I'm going to get off this, go on to the next slide, and hope that others, that's still emergency there. All right. How are we going to treat that hypertensive emergency? Okay. IV nitroprusside, we're going to get them over to the hospital. Get them out, get them gone, get them to the hospital. Okay. If you're in the emergency room working, remember, as you all know, that nitroprusside is light sensitive. Remember those cute little foil wrap brown bags that we used to get to hang up there to hang that nitroprusside? Okay. It's light sensitive. Okay. It's a drug within the IV tubing as well as the bag. Okay. Have y'all ever hung nitroprusside? Anybody? Yes. When you're doing this, you want to titrate that carefully and make sure you're monitoring for rebound hypertension when the medicine's discontinued. Also monitor for acute hypotension, which can then lead to coronary artery spasm, which then can lead to, of course, the ischemia. So you'll make sure you're very careful when you're using that nitroprusside. Substance abuse. Okay. Consider cocaine or other substance abuse in all patients who present to an emergency department with hypertension-related problems. Okay? To an emergency department with hypertension-related problems. Now, it's not just the ER anymore. It's the walk-in clinic. It's your clinic. It's everywhere. But if it's somebody that you don't know and all of a sudden they've got this unusual hypertension issue, you got to think about the substance abuse issue, okay? Cocaine, methamphetamine, too much caffeine, all this stuff can cause problems. Methamphetamine causes blood pressure elevation. Clues for cocaine abuse are that chest pain, tachycardia, the dilated pupils. They may be restless, agitated, they may be paranoid, low combative, may be sluggish on the other hand, altered mental status, in other words, they may have seizures on you. I don't know. That methamphetamine, you can't miss meth mouth. Okay, those teeth are decayed. The face is pockmarked. Even with early meth use, you see those changes, that acne on their face. Okay, I have been amazed how quickly you will see those acne changes. Okay, oh, thank you, Kelsey. We talked about the clothes of cocaine. Nitroglycerin is indicated for cocaine-related hypertension. Given nitroglycerin, it comes down pretty quickly. Also helps dilate those vessels to the heart. Acute amphetamine toxicity is similar to cocaine, and the treatment is also similar to that as well. Okay, so that would be similar treatment for the methamphetamine overdose there. Blame breathing CVAs related to hypertension related to an acute drug overdose. Brittany's comment about. That's true. We do see that a lot. Those patients that are younger that have those acute strokes or blind bleeds secondary to those drug abuse. Postural hypotension is often associated with dizziness and more frequent in an older patient with systolic hypertension only, patients with diabetes, patients who are on diuretics. Some patients who take some certain psychotropics can also have some postural hypertension. Alpha blockers, notorious for the postural hypertension, so is Viagra and anything that falls into the line of Viagra, which includes all those little medicines, okay? The way to try to fix postural hypertension is to prevent it in the first place. Remind them, change position slowly, wait to a count of 10 before you get up and go walking off. Don't walk rapidly. Try to slow down your walk. Make sure you get something nearby to hold on to. Avoid volume depletion. Make sure you stay hydrated, okay? And don't titrate those drugs rapidly. Take your time. Try to get it down slowly but surely. Okay, are you ready? Okay, we're fixing to talk about the AHA ACC guidelines. So everything up to now has been a little bit of JNC7, mainly JNC8. Here we go. AHA ACC 2017 guidelines, okay? That's everybody. So you got the ACC, American Cardiology College, College of Cardiology, American Heart Association, the American Association of Pulmonary, maybe, I don't remember, ABC, which in Alabama is the Alabama Beverage Control, but that's not who that is. ACPM, American Gerontology Association Society, APHA, ASH, ASPC, NMA, and PCNA, which is Preventive Cardiology Nurses Association. I got that. So all these people came together and came up with the guidelines for prevention, detection, evaluation, and management of high blood pressure in adults. Okay? All these people came up with this thing. Okay? Okay, so what do these guidelines say? They stress accurate blood pressure measurement. It is hugely important, okay, to measure that blood pressure accurately, okay? Second of five things, it gives you a new classification system to look at. This is a different way to choose treatment while taking into account cardiovascular risk as well, okay? It lowers blood pressure targets, and it puts an emphasis on lifestyle approach and offers suggestions for controlling BP. So the five things that these new AHA, ACC guidelines do for us are stresses the accurate blood pressure measurement, hugely important. Are we taking it the right way? Are they taking it the right way? Do we know what we're doing? They give us new classification for blood pressure. What is high blood pressure? What is not? They give us different ways to choose treatment while thinking about cardiovascular risk factors for this patient. Lowers the target BPs and puts an emphasis on lifestyle approach first while offering suggestions for controlling blood pressure. Okay. Reclassification stages according to the ACC AHA. Okay. And now less than 120 and less than 80 is still a normal blood pressure. But 120 to 129 is considered an elevated blood pressure now. How many of y'all have taken your blood pressure lately? Has anybody had a blood pressure that feels like they can share? And are you at elevated BP, stage 1 or stage 2? I checked mine, and I am less than 120. It was like 112, I think, and my diastolic was 76, or maybe it was 72 when I checked it last, which was not tonight. Okay, but it was last week when I checked it in preparation for this. Okay, you want 20 over 60, good for you, Patrice. If you're running that 130, you're stressed. Okay, well, you've got the elevated BP, Brittany. We better check you sitting and standing on more than 2 office visits. See, now it's better. That's why it's important to have those 2 different checks, okay? So stage 1 hypertension, which used to be pre-hypertension, is 130 to 139, or diastolic of 80 to 89, okay? That's now stage 1 hypertension. Wow! How many people did you see in the office today that had a blood pressure systolic of 130 or higher? Everybody I saw, well, not everybody. I think I saw 2 today at the nursing home that didn't have a blood pressure of 130 systolic. Wow. I was just like, really? And then stage 2 hypertension, right here, starts with a diastolic of obviously 90 or higher, but a systolic of 140. excuse me, I'd like to speak to you, Miss Smith. You're in stage 2 hypertension. What? People are going to just freak out over this. Now, what they are trying to do about this, okay, is that they are trying to educate us that we need to take this more aggressively and try to prevent more heart disease and try to get us to live longer and do better about what we're taking care of here. But wow, these are some pretty stringent guidelines. Okay, Melody, let's look at you, Melody. It says it's not a governing body. Okay, the governing body is JNC 7. Okay, very good point, Melody. No, that should be JNC 8. Anyway, JNC 7, JNC 8. JNC 8 being the most current guidelines, okay? That is the governing body, okay? ACC and AHA are making suggestions that the national guidelines be adopted to this. I need to fix the slide and make it reflect JNC 8 rather than that. But evidence-based practice, yes. Until the national governing body says this is what it should be, okay? Let's see, how can I put that? We can choose to take that recommendation of ACC, AHA. We can choose to do that if we want to be highly aggressive with our patients and feel comfortable because they have a lot of material behind that. But would you be legally bound to those guidelines because it's not been affirmed by the national organization that sets guidelines? I would think no. Yes, Cynthia, let me go back and look at that and see. JNC 8 doesn't have the guidelines quite like this, the pre-hypertension guidelines, remember? So that JNC 7 may be right. I've got to go back and look at that. Okay. And the more I think, and I'm sorry, I've been talking so long, my brain's a little foggy. I'm 99% sure my slide is right because JNC 8 does not have pre-hypertension. It goes from normal BP to stage 1 hypertension. Okay. So that should, and this is a new slide, so this should be right. JNC 7 has this, and then the 2017 guidelines have this. We still treat JNC 8. Way confusing. But you need to know these AHA, ACC guidelines, and you need to know the JNC 8 guidelines. Okay. But for comparison purposes, we're looking at JNC 7 here to compare it to what it was in JNC 7 and compare it to what it was to ACC. Okay. So let me backtrack one more time. These are suggested and these are recommended by a whole host of people. Okay. All these national groups say you should follow what we suggest and treat these patients to this. Okay. But our national guidelines say this. Okay. Okay. Got it. All right. Stage 1 hypertension will now be with a systolic of 130. Again, how many patients did you see today that have stage 1 hypertension? You go from 31% or 32% to 45, 46% of the population would now have stage 1 hypertension. Okay. So you go from 72.2 million people to 103.3 million people with hypertension. Boom. With one recommendation. That's huge. Yeah, absolutely, Kelly. You're right. 1 cup of coffee makes 100%. Those are huge numbers. Okay. That's my shock face. That still cracks me up. Okay. So what are you going to do? You're going to use these guidelines to your best advantage. Okay. All right. That's what you're going to do. Your older patients may not tolerate these new low blood pressure requirements. They will faint. Literally. They'll just go poop and just pass right out. Or they'll get so dizzy and stand up and they fall and break a hip. So you're going to have to kind of work to your best advantage. Okay. But younger patients and younger patients with diabetes and middle-aged patients with diabetes, if you are aggressive with them and treat them to these guidelines, okay, here, treat them to these guidelines, then you may prevent a heart attack down the line. Okay. But some of these older patients, you may not get there with them. Okay. Just like elderly patients, I'm talking about 75 and older. When I talk about elderly, you may not get them to an A1C of 6. You may be happy with the A1C of 7.5 to 8 because that's what they can best tolerate. Okay. So use your judgment. Okay. Now, and then we're going to look at stage 1 hypertension treatment. Okay. It begins with assessing the cardiovascular risk. Yes, lifestyle medications are great, Rebecca. You're right. What is their risk for clinical cardiac disease? Okay. If they have a risk factor of 10% or higher risk of atherosclerotic disease, start them on medication. Okay. If they don't have a 10% risk or higher risk of heart disease in the next 5 to 10 years, then you want to try that diet and exercise program. Okay. That's the whole thing. Try to get them started on a healthy diet and exercise program, which is what Rebecca said. Okay. That she said lifestyle modifications would probably be better. If there's a risk factor for heart disease is more than 10% in the next 5 to 10 years, particularly 10, then you want to start them on the medication. Otherwise, stage 1 hypertension should be given diet and exercise, which is what the cornerstone of the new guideline is. Okay. Lifestyle modifications. Lose weight. Lose weight, lose weight, lose weight. Follow the DASH diet. Okay. Stick with that less than, we talked about earlier, 1,600 milligrams. This recommends less than 1,500 milligrams of sodium intake per day. Okay. Increase the potassium to 3,500 milligrams daily. You want to make sure they're getting, so not only you're cutting sodium down, but you're pushing up the potassium. 3,500 milligrams daily of potassium, not necessarily, I'm going to take 20 milligrams of potassium, blah, 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 and then you have to convert the milliequivalents to the milligrams, but you're trying to get in the dietary. They're eating more fruits, okay? More vegetables, things that are higher in potassium, particularly those fruits. Physical activity, at least 20 minutes 3 times a week. I was grading my CHAs, and they were talking about how patients should have 150 minutes of exercise. Y'all did such a great job, clinical group. Of 150 minutes of exercise a week, which works out to be 30 minutes 5 days a week. With this, they're just asking for a minimum of 20 minutes 3 times a week. Okay. Cut the alcohol out. The alcohol is making all this worse. Cut it down to 2 drinks or less per day. That's a big deal. A DASH diet likes 1,600 milligrams or less. These guidelines, the AHA guidelines, are 1,500 milligrams or less. It will be very clear if I ask that. Promise. If I ask that. Because that's 100 milligrams. That's splitting hairs over 100 milligrams. You see what I'm saying? That would be really rough. Okay. Cardiovascular risk prediction. Thank you. Okay. Take the quiz, which is that cohort equations. Check your blood pressure at least 3 days per week, and what are your numbers? Okay. So let's talk about that. There's that quiz. This link should work for you. Okay. Take it and see what your risk was. Okay. I think I took mine. Okay. I can't remember I did. And look at your numbers. Okay. And thank you for that, Kelsey. And come up, mine was less than 10% risk over the next 10 years. Can't remember what it was, but it was less than 10%. So that was good. And think about, do you need to practice what you preach? Do you need to do what you're telling your patients to do? Okay. Can't be hypocritical here. Okay. And finally, we're to the end. Mind blown. We're done. Jackie Chan. We're done. Okay. Questions, thoughts, or concerns. And thank you so much for your patience. I know I've wandered all over the place. And if you are not live with us, I'm sorry I've had to listen to my wondering about here. But I want you to be engaged in this. I want you to get the buy-in. I want you to, listen to it, do this. Will this recording be available, Amanda, within a couple of hours, I think? Because what I'll do is I'll close this meeting, and then it should reset itself and be available. Menopause, osteoporosis. I don't know, Melody. There's only so much I can say about hormones. It's pretty cut and dry in there, but I'll look at it and see. That was last year. This is 2018. Okay. Isolated ISH, Shannon, isolated systolic hypertension. That's what ISH is. And Dr. Lang did some stuff did this unit in 2017, and 2016, and 2015. And Dr. Turnham has it in 2018. Yes, that would be it, Shannon. High systolic blood pressure, yes. So I'm kind of feeling my way through the unit and updating stuff as I went along. So, and that's why some of the links didn't work, because I thought they worked and they were right. And I was using mainly what she had already done. Because when one person goes in and works hard to create all this stuff, and you have to go back and freshen it back up a little bit, some things get missed. So I apologize for those links that were not correct. Okay, good. What else? Any other questions? Unit 2 exam, what should we focus on for this unit? A little bit of everything. Did Miss Herf do 30 questions on her last test? I like to be consistent with her. There'll be 30 questions. There's going to be a lot on hypertension. There's going to be some on anemia, not as much as hypertension. There's going to be some on menopause. There's going to be some on osteoporosis. So we got a lot of topics to go over. Basic, any medication doses we need to know. Yes, basic medication doses. What are your standard medication doses for your antihypertensives? Okay. I have to have at least one peds. Let me go. Hang on. I'm reading ahead. Sorry, Becca. Hold tight, Kelly. Basic blood pressure medication doses. You got to know this. You cannot be prescribing if you don't know blood pressure medications. Standard things. Okay. I expect you to know, things like lisinopril and HCTZ and Lasix and Bmax and Xeroxilin, and those things are all standard. Okay. So are Cozar and Hyzar. Those things are standard. You need to know those doses. Because you got to prescribe them. If you don't know them, you can't prescribe them. You also need to know basic hormone doses. Okay, for sure. You need to know osteoporosis drug doses. Those are pretty simple. Those are pretty standardized across the board. Yeah. Calculations for the peds. Yes, at least one, maybe two. Thank you for reminding me about that, Rebecca. JNC 7 is provided for reference, because you got to know where you've been to know where you're going. I may have one tiny question on JNC 7. Maybe. Everything else is pretty much, you got to know it. And there's a lot of material. But just think, don't panic. Don't panic. Think as you read the question. Think about what is presenting to you and is staring you in the face. Not what if this, or what if that, or what if this, oh, and what if this. No, we can't do that. We have to just focus on what's right there on black and white on the paper. Okay? Don't read into it. Okay. Melody was, do we need to know hypertension classes or generic names or trade names? Yes, you need to know all the above. Because otherwise, you won't know. You need to know what are diuretics, what are loop diuretics, what are thiazide diuretics. You need to know what are ACE inhibitors, what are ARBs, what are beta blockers, what are calcium channel blockers, what are alpha blockers. We need to know those things. I will give you generic and trade names together. Okay, and they'll be right. I won't, they'll be right. So amlodipine is Norvasc, that kind of thing. I will give you amlodipine and Norvasc together at the same time. All right, other questions? Again, I thank you all so much for your time and your patience as I've wandered off on little rabbit trails here and there, and I keep hearing foreigners singing "Emergency" in my head. And I hate when stuff like that happens. The cake is gone, Cynthia. I think it's just gone. But thank you for thinking that. 'Cause I can smell burning pound cake bits back here, and I'm gonna go start over again. I pulled out some extra butter. Go start a new pound cake. Ah, okay. Anything else from anybody else? Thank you. Okay. I'll be checking the forums, and yes, butter is on the dash diet, Melody. Thank you. Butter, not margin. Butter. Um, Margin's not healthy. Butter's good for you. It's full of good fat. No, because I'm under 1,600 milligrams so far today. I skipped lunch. I had a protein shake for breakfast. But anyway, I hope this is helpful, and y'all will soon have Miss Herfack and I think Dr. Washington maybe teaching this semester also. I can't remember, but I will do this. But I will look and see if we need to have a PowerPoint or anything else. Anemia, I think the anemia stuff I pretty much broke it down for you pretty well. Hormones, I'll look at the hormone thing, but I think we're probably good. Okay. All right. Well, thank y'all so much. Have a good night.